I knew something was off the Monday morning. I walked into the data center on the third floor of Northgate Regional Health and heard nothing but the hum of the HVAC. Not the usual rhythm of keyboards, not the low murmur of my team running pre-shift checks, just that hollow, air-conditioned silence that tells you something's already gone wrong before you've even taken your coat off. My name is Colin Mercer. I'm 54 years old, and for 11 years I was the Senior Clinical Systems Administrator at Northgate Regional Health in Edmonton, Alberta. That sounds bureaucratic, I know. What it actually means is that I was the person responsible for keeping the medication management platform running for a 740-bed hospital. Doctors ordered drugs through my system. Nurses verified doses through my system. Pharmacy dispensed through my system when it worked, and it almost always worked. Nobody knew I existed. That's the job. You're invisible until you're not. Let me tell you something about hospital medication systems that most people don't understand. They're not like running a spreadsheet for your small business or managing inventory for a furniture store. Every single transaction in that system has a clinical consequence. A wrong decimal point isn't an accounting error you fix next quarter. A misconfigured dosage alert doesn't just cost money. I'd spent 11 years building something that understood the difference between a 40-year-old patient with no comorbidities and a 78-year-old with renal impairment. Because the same drug at the same dose can do very different things to those two people. The pharmacist knew me by name. The nursing directors called me directly when something looked strange. That's how embedded this stuff was. Northgate got acquired by a private health services company called Meridian Health Group in the spring. Meridian owns 11 facilities across Western Canada, long-term care homes, surgical centers, one other regional hospital. They moved fast. Within 6 weeks of the acquisition closing, we had new leadership installed at the executive level, new branding in the lobby, and a new VP of digital transformation named Derek, who showed up wearing dress shoes to a hospital and never seemed to take them off, not even when he toured the oncology ward. Derek was sharp in the way that people who've never done the actual work can sometimes be sharp. Good with a PowerPoint. Comfortable in a boardroom, he had a way of making fundamental misunderstandings sound like strategic insights. He'd say things like, "We need to sunset legacy dependencies," and what he meant was, "Fire the expensive people and buy something cheaper." I'd seen that translation before at my last employer, a logistics firm in Calgary that replaced their customs compliance team with a SaaS platform and spent 3 years fixing the fallout. The meeting happened on a Wednesday afternoon. Derek called me into the small boardroom off the administrative wing, the one with the frosted glass walls and the view of the parkade. My manager, the director of IT, was already sitting there looking at her laptop with the expression of someone who already knew what was coming and deeply wished she didn't. Derek didn't waste much time. He said Meridian was standardizing its digital infrastructure across all facilities, moving to a unified platform. He said it would improve interoperability and reduce overhead. He used the word synergies twice in 4 sentences, which is always a bad sign. Then he told me he wanted me to meet someone. His nephew came in right after, carrying a laptop bag that looked brand new. 26 years old. MBA from a school in Ontario I'd heard of but wasn't particularly impressed by. He'd done his thesis, apparently, on digital health transformation in mid-sized Canadian hospital networks. He shook my hand and said he was really excited to modernize what I'd built. I asked what the plan was, specifically. He opened his laptop and showed me a Google Sheets document. Not a system, not a platform, not even dedicated software. A spreadsheet. Color-coded tabs, drop-down menus, some conditional formatting that turned cells red if a number exceeded a threshold. He called it a dynamic clinical workflow tool. He said it was cloud-native, user-friendly, and could be deployed immediately without the licensing costs of our current system. I sat with that for a moment. I said, to be clear, you want to manage medication administration for 740 inpatients using Google Sheets. He said it wasn't just any spreadsheet. It had macros. I looked at Derek. Derek was nodding like his nephew had just explained cold fusion. I said, all right, I want to make sure you understand what the system currently does, because I don't think you do. I started listing. We have drug-drug interaction checking against a database that updates quarterly from Health Canada. We have weight-based dosing calculations for pediatric patients that pull live from the patient record. We have allergy cross-referencing that fires an alert if a nurse tries to administer anything in the same class as a documented allergen. We have renal dosing adjustments that modify the recommendation automatically based on the patient's most recent creatinine. We have controlled substance tracking that satisfies Alberta Health Services reporting requirements. We integrate directly with the lab system, so if a patient's potassium comes back critical, the system flags any pending orders for medications that could make that worse. The nephew was nodding. Not the nod of someone following along. The nod of someone waiting for you to finish. He said his model included lookup tables for all of that. Lookup tables. I thought about the pediatric oncology unit on the 5th floor. I thought about a 7-year-old whose methotrexate dose is calculated based on body surface area, adjusted for renal function, cross-checked against their current antibiotic because some antibiotics raise methotrexate toxicity. I thought about that being managed with a lookup table in a Google Sheet. I looked at Derek and I said, this isn't a business process. This is clinical decision support. If it fails, people get hurt. Derek said the cost savings would allow Meridian to reinvest in patient care. That's when I understood we were done talking. That sentence, reinvest in patient care, is what executives say when they've already made the decision and want to feel good about it. My director sat quietly through most of this. She told me afterward, in the hallway, that she pushed back through 3 separate meetings and been overruled each time. She looked tired in the way people look when they've been fighting something for weeks and finally stopped winning. They gave me 4 weeks. They wanted me to document everything, train the nephew, and hand over system credentials before my last day. I said I'd do the documentation. I wasn't going to pretend the handover was going to work, but I'd give them what they asked for. Those 4 weeks were surreal. The nephew shadowed me every morning, taking notes in a Notion doc on his laptop with the kind of concentrated energy you see in first-year students who haven't figured out yet which information is important. He asked smart enough questions. That was the frustrating part. He was smart. He just had no idea how deep the water was. One morning, I was walking him through the renal dosing module, and he asked why we didn't just use the standard formula. I said because the standard formula assumes normal muscle mass, and a significant portion of our elderly patients have sarcopenia, which throws off the creatinine-based calculation. So we built a correction factor that also pulls the patient's recent weight trend. It took me 8 months to develop in consultation with a nephrology team. It's not documented anywhere except in the code and in my head and in the memory of Dr. Abiyoy in nephrology, who helped me design it. He made a note that said renal dosing complex needs review. I didn't say anything. Some lessons you can't shortcut. By the end of week 3, he'd started importing real patient data into the test version of his spreadsheet. Not live data. A de-identified set we used for system testing. Within 2 hours, his drug-drug interaction logic was returning false negatives on warfarin NSAID combinations because he'd structured his lookup table by generic name and we had 3 different brand names in the dataset for ibuprofen, none of which matched his lookup key. I told him. He said he'd add the brand names to the table. I said there are over 20,000 drug products currently approved in Canada. Brand names, generics, regional variations. The interaction checking works because it uses DIN codes and ATC classifications, not names. Names are unreliable. Names change. Companies get acquired and rename products. You cannot build safety logic on drug names. He made another note. I stopped trying after that. Not because I didn't care, because I'd realized I was trying to compress 11 years of clinical informatics experience into 3 weeks with someone who had an MBA and a good attitude. And that wasn't a gap that documentation was going to close. My last day came in October. I cleaned out my desk. A few books. A photo from a ski trip in Jasper. A thermos I'd had since my last job. One of the nursing informatics leads came down from the 3rd floor to say goodbye. She hugged me and said, between us, she was terrified. I told her to document everything she noticed going wrong from day 1. She said she would. I drove home up White Mud Drive in the early afternoon, which is a strange thing to do on a Tuesday when you've worked days for 11 years. I stopped at the Tim's on the way and sat in the parking lot drinking a double-double and thinking about what I was going to do with myself. My phone started buzzing at 7:43 the next morning. It was one of the pharmacy technicians I'd worked with for years. She said the overnight medication reconciliation had produced output she didn't recognize. Patients admitted the previous evening were showing drug orders in the system that didn't match what had been prescribed. One patient in the medical unit had an antibiotic flagged as active that had been discontinued 2 days before admission. I said I wasn't an employee anymore and she should escalate to IT. She said IT had already been called and the nephew had been there since 6 in the morning trying to fix it. I said I was sorry and I hoped it got sorted. I sat with my coffee and tried to read the news. My phone buzzed again at 8:20, then at 8:55, then 3 times in a row just before 9, which is when I stopped pretending I wasn't going to get involved eventually and started actually reading the messages. The picture that assembled itself over the next hour was worse than I'd expected, and I'd expected something bad. The nephew had built his spreadsheet to pull patient data from our EMR through an export function, a flat CSV file generated manually and imported into his Google Sheet each shift. What he hadn't accounted for was that our EMR uses a proprietary patient identifier format that changes structure depending on the care setting. An inpatient identifier looks different from an emergency identifier, looks different from a surgical day patient identifier. His import logic treated them all the same. When he imported the overnight data, identifiers had cascaded incorrectly across rows. The system hadn't crashed. That would almost have been better. It had quietly scrambled. Medication records for one patient were sitting under another patient's identifier, not for everyone. For about 12% of the overnight admissions, by 9:30, the charge pharmacist on the morning shift had caught 3 near misses during the manual verification process that our accreditation standards thankfully required as a backstop. A dose of digoxin that belonged to a 71-year-old cardiac patient had been associated with a 34-year-old admitted for a knee replacement. The dose itself was fine for the cardiac patient. For someone with a healthy heart and no existing prescription, it would have been a problem. The pharmacist had caught it. That's what the manual verification process is for. But the manual verification process exists as a safety net, not as the primary system. They'd caught 3. The question was whether anything had gotten through before the shift. Pharmacist arrived and started reviewing. Derek called me at 10:15. He didn't say good morning. He said they had a situation. I said I'd heard. He said he needed me to come in. I said I wasn't an employee. He said he understood that. I told him I'd need to think about what that looked like. I said I'd call him back in an hour. I spent that hour making a few calls, one to a friend who's an employment lawyer in Calgary. We went to university together, and she owes me from a fantasy hockey draft that got very complicated one year. I asked her a few questions. She gave me some very clear answers about what my position was. Then I sat down and wrote out what I needed. I called Derek back at 11:30. I said I'd come in as an independent consultant. My day rate was $2,200, invoiced daily, payable before I arrived each morning. I'd work until the system was stabilized and the clinical risk had been mitigated. I wanted a written agreement that my scope was purely technical remediation and that I had authority to halt any clinical process I identified as unsafe pending review. I wanted that in writing from the CMO, not from Derek. And I wanted it on the record that the root cause of the incident would be accurately described in any documentation submitted to Alberta Health Services, not unforeseen integration complexity, not transition challenges, the actual cause. Long silence. Derek said some of those terms were unusual. I said the situation was unusual. Another silence. He said he'd have to get back to me. I said I'd be available until noon. After that, I was going to call a colleague at the University of Alberta Hospital to see if they were hiring. He called back at 11:53. I was in the building by 1 o'clock. My badge had already been deactivated, so they had to issue a contractor pass. The security guard at the main desk was someone I'd known for years. Retired RCMP, keeps a thermos of rooibos tea on his desk no matter the season. He gave me a look when he saw me and said, "Thought you left." I said, "They asked me back." He shook his head and gave me the visitor lanyard. The server room felt like a place I'd been away from for longer than 2 weeks. The nephew was sitting at my old workstation looking the way people look when they've been awake for 8 hours trying to hold something together with their hands. Not incompetent. Overwhelmed. There's a difference, and it matters. He was overwhelmed by something that was bigger than he knew. I didn't make him feel worse about it. I just sat down and started working. The data integrity issue took me 6 hours to untangle. The identifier mismatch had affected 94 patient records. I wrote a reconciliation script that cross-referenced the scrambled records against the EMR audit log. The EMR keeps a timestamp and sequence record for every transaction, which meant I could reconstruct what the correct assignment should have been. I ran the reconciliation, flagged everything for manual clinical review, and had the charge pharmacist and the nursing supervisor sign off on each corrected record individually before I touched anything. It was careful work. It was slow. I drank a lot of bad coffee from the machine in the IT lounge and ate a sandwich someone brought me around 5 in the evening that I think was tuna, but might have been salmon. By 8 o'clock that night, the immediate risk was contained. Every affected record had been reviewed by a clinician. No adverse events had been confirmed, though the quality team would be doing a full retrospective review for the next several weeks, which was right and appropriate. I spent the next 4 days rebuilding the integration layer properly, not the Nephew spreadsheet. I wasn't going to try to fix that. I wrote a proper middleware component that pulled from the EMR using the API that the EMR vendor provides and that I'd been using for 9 years, mapped the patient identifiers correctly across care settings, and fed sanitized data into a reporting layer that the Nephew's team could actually use for what it was suited for. Reporting and analysis, not clinical decision support. I was clear with Derek and with the CMO, Google Sheets was not going back anywhere near clinical workflow. It could be used for operational reporting. It could not be used for medication management. The CMO, to her credit, had already come to the same conclusion on her own. She'd been asking questions since the morning of the incident that Derek had not enjoyed answering. On my last contracted day, I met with Derek in his office. He looked better than he had the week before, but still not good. He told me Meridian was going to retain our existing clinical platform. He said they'd underestimated the complexity. I said that was accurate. He said they'd be looking for a permanent solution and that my contract rate was not sustainable long term. I said I understood that, and if they wanted to discuss a permanent arrangement, I was open to it, but my requirements had changed. I wanted to report to the CMO, not to digital transformation. I wanted a written mandate that clinical systems decisions required sign-off from a clinician with privileges at the facility, not just a VP. And I wanted my salary adjusted to reflect market rate for clinical informatics in Alberta, which I'd looked up and had the numbers ready. Derek said he'd need to take it to Meridian leadership. I said that was fine. I'd already had one conversation I didn't expect to have, and I could wait for another one. 3 weeks later, I got an offer letter. New title, Director of Clinical Informatics. Report line to the CMO. Salary that made the previous number look like a suggestion. And a clause in the mandate document, signed by the CMO and the board chair, that any proposal to replace or substantially modify a clinical support system required a formal clinical risk assessment completed by a qualified pharmacist or physician. That clause didn't exist anywhere in the organization before all of this happened. It exists now. I moved back into the same office I'd had before, which they'd given to someone from Meridian's project management team in the interim. He'd rearranged the furniture, which I rearranged back. There was a card on the desk from the pharmacy team. 15 signatures and a gift card to a wine shop on Jasper Avenue that I took very seriously. The nephew is still with the organization. He's working on operational reporting and data analytics, which is genuinely what he's good at. I've had 2 decent conversations with him since I came back. He's not a bad person. He was put in a position by someone who didn't understand what they were asking him to do. That's not entirely his fault. I've said as much to the people who asked me about it. What I've thought about since, honestly, is the comment my employment lawyer friend made when I called her that morning. She said, "You know what the most expensive thing in healthcare is? It's not the equipment. It's not the specialists. It's the people who know where the bodies are buried and choose not to talk." She meant it as a compliment. I think about it differently. The bodies shouldn't be buried in the first place. Systems that keep people safe shouldn't live entirely in one person's head. That's on me as much as anyone, but some things you can't hand off in a training document. Some things you have to earn by being there when it goes wrong at 6 in the morning and again, until you start to know things you can't fully explain but can absolutely act on. That's not mysticism. That's experience. And the day we stop paying for it is the day we find out what it was actually worth. I poured myself a proper drink that Friday evening, a rye from a distillery near Canmore that I'd been saving for something, and I looked out the window at the parkade and thought about the 740 people sleeping in beds on the floors above me, most of whom had no idea any of this had happened. That seemed right. That's exactly how it should be. The thing I keep coming back to, sitting here months later, is that rye I poured on that Friday evening. Not because it was a celebration exactly, more because it was the first quiet moment I'd had to actually think about what the whole thing meant. Derek made his decision based on what looked good in a budget meeting. His nephew built something he genuinely believed in, and I don't think badly of him for that. But there's a kind of thinking that mistakes confidence for competence, and that confuses a clean presentation with a working solution. That thinking has consequences. In this case, the consequences showed up at 6 in the morning when a pharmacist caught a digoxin dose assigned to the wrong patient and had to manually pull the record to correct it before anything reached the ward. That pharmacist caught it because she was careful and because she'd been trained to verify. That's integrity, doing its job in the most literal sense. Not as an abstract value, but as a daily habit of checking your work even when no one's looking. Even when the system says it's fine. Even when you're 40 minutes into a shift and the coffee hasn't kicked in yet. I've thought a lot about whether I could have done more to prevent what happened. The honest answer is, probably. I could have been louder in those last weeks. I could have escalated differently, gone around Derek to the CMO earlier, put more in writing. I chose to do the job I was asked to do and trust that reality would make its case. Reality did. But people were at risk in the window between those two things, and that's not something I'm entirely comfortable with. What I've learned, not just from this, but from 20+ years of working in systems that matter, is that real expertise is slow. It accumulates in ways that are hard to see and impossible to shortcut. The correction factor I built into the renal dosing module, the one that accounts for muscle mass in elderly patients, didn't come from a textbook. It came from 18 months of working alongside Dr. Abioy and reading every nephrology consult note I could get my hands on and getting it wrong twice before I got it right. You can't hand that off in a training document. You can't replicate it with a lookup table. The willingness to stay with a hard problem long enough to actually understand it. That's something you have to decide to do over and over when it would be easier to call it close enough. The clause in the mandate document, the one requiring a formal clinical risk assessment before any system change. That's the part of this story I'm most glad about. Not my salary, not the corner office. That clause, because it means the next time someone shows up with a Google sheet and a good attitude and a family connection, there's a process that requires a qualified clinician to sit down and ask, what happens if this fails? Who gets hurt? What's the recovery plan? That question is what I wish Derek had asked before he called me into the boardroom. Not out of malice. I don't think he's a bad person. I think he was doing exactly what his incentives told him to do, and nobody in his chain of command had built a structure that forced him to slow down. That's not just a problem for hospitals. That's a problem everywhere. That decisions get made by people who are insulated from the consequences of being wrong. I think about the 740 people who were sleeping on those floors and had no idea any of it was happening. That anonymity, that's the goal. That's what doing this job well looks like. Nobody knows your name until something goes wrong, and if you do it right, something almost never goes wrong. There's a kind of quiet satisfaction in that if you're willing to look for it. That rye from Canmore was excellent, by the way. I've since bought another bottle. Some things earn their occasion.